Hello, welcome to the Center for Connected Health Policy's Telehealth and Medicaid Policy Webinar Series, Spring Edition. Today's topic would be Telehealth Policy for Mental and Behavioral Health. My name is May Kwong. I'm the Executive Director at the Center for Connected Health Policy. Next slide. A few disclaimers and friendly reminders and housekeeping information. So please note that any information provided in today's webinar is not to be regarded as legal advice. Today's talk is purely for informational and educational purposes. CCHP always recommends, if you are interested in a formal legal opinion, to please consult with legal counsel. Also, if a product or a company is mentioned in today's talk, know that neither CCHP or any of the panelists have any type of relationship, affiliation, or financial interest with such an organization. Today's webinar is being recorded, and the slides and the recording of the webinar will be made available several days after this webinar takes place on CCHP's website at cchpca.org and on CCHP's YouTube channel. Also note that for today's webinar, closed captioning is available. You'll see on the toolbar below that there's a closed captioning button, so you can press that if you would like to have closed captioning, the closed captioning option for you. We ask also that you please refrain from political statements or advertising commercial products or services during this webinar. Again, this webinar is strictly for educational purposes, so we ask that you do not make any political statements or advertising in either the chat or the Q&A box. If you have questions for our panelists, please utilize the Q&A function. The chat function should only be utilized for technical issues related to Zoom. Next slide. A bit of background information about CCHP. We were started as a California telehealth policy organization as a program underneath the Public Health Institute in 2009. An opportunity to become the federally designated National Telehealth Policy Resource Center became available in 2012 through a grant from HRSA. CCHP applied for that, we got it, and we've been serving in that capacity ever since. We also work with a variety of other funders and partners on the state and federal levels on various telehealth or connected health projects. We act as an administrator for the National Consortium of Telehealth Resource Centers, and we convene a group in California called the California Telehealth Policy Coalition, which is a coalition of over 100 statewide organizations and individuals who are interested in advancing telehealth policy in the state of California. Next slide. The National Consortium of Telehealth Resource Centers is made up of the 14 telehealth resource centers who are underneath the same grant program as CCHP. There are 12 regional resource centers that cover specific states and 2 national centers, one on technology based out of Alaska and one on policy, which is CCHP. The 14 telehealth research centers work collaboratively together on joint projects and efforts. If you reach out to one TRC, I like to say you actually get all 14 of us. Next slide. Today's webinar, as I mentioned at the top of it, will focus on mental and behavioral health and policies related to those in the Medicaid program. This is the final webinar for our spring series, but there will be a fall series in a few months as well. Next slide. Today's speakers will hear from the Texas Health and Human Services Commission, followed by the Kansas Department of Health and Environment, Division of Healthcare Finance, and Mass Health will wrap it up for us. So first off, we will start off with our speakers from Texas. We have with us today Erin McManus. Erin has worked for the state of Texas for 9 years. She has worked for 6 years as a policy analyst and as a public policy advisor in the Medicaid CHIP Services Department at the Texas Health and Human Services Commission. In these positions, she has served as the department's subject matter expert for telemedicine and telehealth services. She has a Bachelor's of Arts in Anthropology and a Master's of Public Affairs, both from the University of Texas at Austin. We also have with us Tamara Boyd Ostrout, who has worked for the state of Texas for a little over 11 years. She's worked for the state hospital system of Texas as the continuity of services coordinator and clearinghouse forensic waitlist coordinator for almost 5 years, and prior to that as a treatment team coordinator for 3 years for the adult and specialty units at Austin State Hospital. She also was the recovery manager liaison for the home and community-based adult mental health program prior to coming to Medicaid CHIP. She's a 2-time alumnus of Texas State University with a Master's of Science in Social Work, Administrative Leadership, and Bachelor's of Arts in Psychology with a minor in Forensic Psychology. Tamara is a native Texan and currently lives in Austin with her husband and many feline fur babies. So I will now turn it over to our folks from Texas. And also note they may be having a little bit of connectivity issues, so their cameras may be turned off. So Tamara?
Great, thank you, May. So good afternoon, everyone. I will be presenting on behavioral health services in Texas Medicaid. Next slide, please. So we will begin with mental health services in Texas Medicaid. Next slide, please. So our mental health services include outpatient mental health services, targeted case management, mental health rehab services, inpatient psychiatric services, and health and behavior assessment and intervention services. Next slide, please. So our outpatient services include psychiatric diagnostic evaluation, psychotherapy in all its forms, individual, group, and family, testing, ECT, and pharmacological management. And right now, our mental health services can be provided in a variety of settings. Our outpatient services in office, home, skilled nursing facilities, outpatient hospital, and many others like a school, homeless shelter, and so forth. Next slide, please. So our providers for outpatient mental health services include licensed practitioners of the healing arts. So that's your clinical social workers, your professional counselors, and so forth. We also allow licensed psychological associates, provisionally licensed psychologists, postdoctoral fellows, and pre-doctoral psychology interns to provide outpatient mental health services, but they must do it under the supervision of a licensed psychologist, and they would actually bill for those services under the licensed psychologist. Next slide, please. So targeted case management, this is a benefit for persons of all ages who have a DSM-5 mental illness diagnosis and who have also been determined to be in need of TCM via a uniform assessment process. We do have two types of targeted case management: routine services, which are available for persons of all ages, and those are typically office-based. And then we have intensive care services for children and adolescents, and those are typically community-based. Next slide, please. So mental health rehab services include crisis services, medication training and support, skills training and development, psychosocial rehab, which is for adults only, and day programming, which is also for adults only. It's important to note that both targeted case management and mental health rehab services in Texas require prior authorization, except for crisis services. Next slide, please. So inpatient psychiatric services. So admissions to an acute care hospital are a benefit of Texas Medicaid for persons of all ages, whether they're in fee-for-service Medicaid or managed care. Admissions to an IMD are a little different. So they are a benefit for persons 20 years of age and younger and 65 years of age and older, whether they're in fee-for-service or managed care. If delivered through managed care, though, services for persons 21 through 64 years of age are eligible for reimbursement as in what we call an in lieu of service, but reimbursement is up to 15 days per calendar month. Next slide, please. So health and behavior assessment and intervention services. This is currently a benefit for children and adolescents, but our governance recently approved expanding this benefit to adults, and we are in the policy development process. Also, Texas Medicaid covers most of the CPT codes for HBIA, but not all of them. One of them we don't cover is family intervention without the patient present. And we do have a variety of approved provider types for HBIA services. Next slide, please. So moving on to substance use services. Next slide, please. So our services include screening, brief intervention, and referral to treatment, or SBIRT, assessment, counseling, medication-assisted treatment, or MAT services, residential treatment, And withdrawal management, that used to be referred to as detoxification services. Next slide, please. Okay, so SBIRT, this is currently a benefit for persons 10 years of age and older who have or are at risk of having an alcohol or substance use disorder. We have several approved provider types for SBIRT, such as physicians, FQHCs, clinical social workers, and so forth. Also, our places of service for SBIRT include an office, outpatient hospital, and effective June 1st, we are adding skilled nursing facilities, extended care facilities, and intermediate care facilities. Now, providers of SBIRT must complete 4 hours of SBIRT training prior to the delivery of services to be reimbursed. And regarding the screening component of SBIRT, our providers must use a standardized screening tool, and we do provide some examples in our provider manual. Next slide, please. So the assessment has to be done face-to-face. However, we do have a COVID flexibility in place right now. It's a multidimensional assessment, and it must be completed by a qualified credential counselor. Next slide, please. So substance use counseling, this includes individual or group counseling. This is typically for persons with less severe disorders or who are in early stages of change. It's also used as a step down from more intensive services. Next slide, please. So MAT is the use of FDA-approved medications in combination with psychosocial treatment. It's a best practice for alcohol use and opioid use disorders. MAT services may be provided by a licensed chemical dependency treatment facility or a CDTF. Also, we have other providers, if it's within their prescriptive authority, they can also provide MAT services. However, methadone must be provided only by an opioid treatment program, or what we call in Texas as a licensed narcotic treatment program. And also, just to note, certain MAT medications are available as a pharmacy benefit too. Next slide, please. So residential treatment services, it's a structured therapeutic environment where people reside to receive substance use disorder treatment. But in Texas, this can only be provided in a licensed CDTF, that chemical dependency treatment facility. Next slide, please. And withdrawal management, again, used to be called detoxification services. We have outpatient, residential, and inpatient withdrawal management services, depending on the severity of the person's symptoms. Outpatient and residential services must be provided in a CDTF. Next slide, please. So additional coverage. Next slide, please. So we do offer peer specialist services for persons 21 years of age and older who either have a mental health or substance use condition. They can be delivered individually or in a group setting. It must be delivered face-to-face, except we do have a COVID flexibility in place right now. It must be included in the person's plan of care or the person-centered recovery plan in order to be reimbursed. Our peer specialists also must complete certification and certain training requirements. And our peer specialists do not bill directly. They must bill through an approved Medicaid provider type. So they have to be employed by an approved Medicaid provider type. Next slide, please. And last, court order services. So court orders are considered the determination of medical necessity. So by example, there are certain court orders that the person is considered incarcerated. For instance, if they've been found incompetent to stand trial and they are sent to an inpatient facility for competency restoration, that particular court order is considered, the person's considered to be incarcerated. So that would not be a covered court order. But for ones that are covered, that we would use that as the determination of medical necessity. And our managed care organizations cannot deny, reduce, or controvert a court order. Next slide, please. So now I will turn it over to my coworker, Erin McManus.
Hi, thank you, Tamara. I appreciate it. I'm Erin McManus. I'll be focusing the remainder of our presentation on telemedicine and telehealth coverage for behavioral health services. Before I go into the coverage details, I did want to take a moment to actually define the two terms on this slide, telemedicine and telehealth services, since those terms do have specific state law definitions in Texas. And I know most payers define these types of services in different ways. So for the purposes of this presentation, telemedicine services refer to direct healthcare services that are remotely delivered by a physician or another practitioner who's under physician delegation and supervision. So we colloquially refer to telemedicine services as physician delivered services. Conversely, telehealth services refer to direct healthcare services that are remotely delivered by a non-physician practitioner. So any other practitioner in the state who is licensed and certified, who can provide remote services within the scope of their licensure, but who's not a physician or under physician delegation and supervision. Next slide, please. Our existing Medicaid coverage, and I'll be dividing out this portion of the presentation into our Medicaid coverage prior to the public health emergency, and then coverage differences, or what Tamara referred to as our COVID flexibilities post public health emergency, and that are currently continuing. Texas Medicaid bases its telemedicine and telehealth covered services off of existing services that are covered for in-person delivery. In most instances, the same procedure codes are used for both remote and in-person delivery. Providers are directed to use the 95 modifier to indicate that remote delivery occurred. Prior to the public health emergency, Texas Medicaid covered a subset of our behavioral health services when they were delivered remotely. And those are the services that are listed on this slide. As you'll see, the services are really focused on things like psychiatric diagnostic evaluations, psychotherapy services, et cetera. Next slide, please. Texas state law specifies the modalities that can be used to deliver a telemedicine or telehealth service. I believe most essential is the requirement that the modality allow the provider to meet the in-person standard of care, so that any telemedicine or telehealth service provides the same level of care as a similar in-person service. As you'll notice on this slide, the Texas state law does not confine telemedicine or telehealth services to only synchronous audiovisual services. So there's no restriction currently that these types of services be provided with a visual component, a synchronous visual component. For example, a synchronous audio call that's coupled with a practitioner's review of images, lab results, or a nurse's notes would be an acceptable delivery modality. Next slide, please. Texas state law also provides coverage exceptions for some of the delivery modalities for our health benefit plans. To date, Texas Medicaid has interpreted these provisions to allow the Medicaid managed care organizations to choose whether to provide reimbursement for telemedicine and telehealth services that are delivered as audio-only calls, text-only messages, and faxes. Next slide, please. In 2019, the Texas legislature passed a bill that granted Medicaid managed care organizations flexibility in the services that they cover as telemedicine and telehealth services. Now, Medicaid managed care organizations may not deny reimbursement for covered health services, which HHSC interprets to mean Medicaid services that are covered, already covered for in-person delivery, solely because the services were delivered remotely. The Medicaid managed care organizations must consider for reimbursement all medically necessary Medicaid covered benefits that are provided remotely. Next slide, please. I'll go ahead and transition now to our COVID flexibilities. In March and April of 2020, HHSC implemented multiple policy flexibilities in response to the COVID-19 pandemic to allow for greater use of remotely delivered services. The policy flexibilities include new coverage for synchronous audiovisual services like mental health rehabilitative services and targeted case management services, the full list you'll see here on the slide as well. We also included peer specialist services. As Tamara mentioned, this was a COVID flexibility, as well as expert and SUD counseling as well. Next slide. We also implemented a number of policy flexibilities that focused on audio-only services. The policy flexibilities provided new coverage for audio-only services that included services like peer specialist, as well as SUD counseling. As you'll notice, some of the services that were newly covered for audio-only delivery were already covered in existing Texas Medicaid policy for telemedicine and telehealth delivery prior to the COVID-19 pandemic. And also as a note, the term audio only in the context of the policy flexibilities refers to a synchronous audio call that could be provided with or without an asynchronous component like practitioner review of a chart, lab results, clinical data, nurses' notes, etc. Next slide, please. As with most state Medicaid programs, Texas Medicaid has experienced significant increased utilization of telemedicine and telehealth services during the COVID-19 pandemic. This does include increased utilization of telemedicine and telehealth services used to treat behavioral health conditions. However, as you'll notice on this slide, even prior to the current public health emergency, telemedicine and telehealth services were overwhelmingly utilized for the treatment of behavioral health, primarily mental health conditions. Texas Medicaid tracks utilization of these services by primary diagnosis, and we do report this information in December of every even numbered year. So every 2 years, we do report out on utilization of specific procedure codes by client diagnosis. Next slide, please. The Texas legislature is currently in session, and legislators have filed many bills that relate to telemedicine and telehealth services broadly. I know this has been the case really across the United States and has definitely impacted many state Medicaid programs. Some bills would make the COVID-19 policy flexibilities permanent Medicaid reimbursement policy. As we await the end of session, HHSC has already begun reviewing many of the COVID-19 policy flexibilities to make clinical appropriateness recommendations and to really look at what making some of these benefits permanent would entail. Next slide, please. And with that, I will go ahead and close and open for questions.
Thank you, Erin and Tamara. We do have a couple of questions for you in our Q&A function. The first one's from Ankit Gupta. I think this may have been in reference to the substance use disorder assessment, but I'm not 100% sure. I'm going by when this question came in, but question is, can the assessment be done face-to-face via a synchronous audio video call?
Erin, did you want me to take that one?
Sure, go ahead, Tamara, and I'll jump in after you.
Okay. So from my understanding, CMS, well, in person and face-to-face are, the difference between the two is face-to-face does allow the audio visual. In person actually means you must be in the same space, in the same physical space. So for this, face-to-face would be the audio visual, and then we have the COVID flexibility that's allowing audio only right now. And Erin, do you have anything to add to that?
No, you captured it, Tamara. Thank you.
Okay. Our next question is from Tanya Harris. And Tanya, there may need to be a little bit of clarification from you. Your question is this a standalone service or embedded inside Texas? Are there various ways they can communicate with the client, such as chatting and or texting, etc.? And I'm not 100% certain what service you're referring to. Is this again referring possibly to substance use peer specialists? She put it in the chat.
So peer specialist services, again, they must be face-to-face, which means audio visual. Right now we have the audio only COVID flexibility. Whether that becomes permanent or not, I guess that will depend on our legislature. But right now, I am not aware of any texting or kind of instant messaging allowed. Erin, did you want to say anything to that?
No, I'm also not aware of specific texting. I don't believe that's something that we specifically track in Texas Medicaid in terms of the different modalities, or would be able to necessarily break out of our claims and encounter data.
Great. We have a question from an anonymous question. What training opportunities are available to help clinicians learn to deliver evidence-based practices via telehealth with appropriate fidelity?
This is Erin. We do have some trainings. They're really more focused on issues of reimbursement. Since we're a payer, that's really most of our focus in terms of training opportunities. They're offered through the Texas Medicaid and Healthcare Partnership, which is our Medicaid Management Information System contractor here in Texas. They have a learning management system that offers those opportunities. It does require a username and password, but it is open to any provider participating in Texas Medicaid, and they have a whole host of videos as well as static resources, and they do offer webinars as well.
Okay, we'll take one more question before we go on to our next speaker. If the therapist is licensed in Texas and the client is in Texas, can the therapist make the telehealth call from a location other than Texas? So I'm guessing this is somebody who is outside of the borders of the state.
So if I'm understanding the question, can a clinician who's licensed in Texas and the person receiving services is a resident of Texas, but for whatever reason, the licensed clinician is outside of the state boundaries at the moment and doing an audio call from Oklahoma, let's say?
I believe that is the scenario that they're sketching out.
So I don't think and I'll defer to Erin, but I think that would be okay if they're licensed and enrolled as a Texas Medicaid provider and they're licensed in Texas. I don't think we would even track that, but Erin, I'll defer to you.
Sure. I don't think I've actually gotten that specific scenario before. I know we've looked at situations where the physical office is outside of Texas, the client is outside of Texas. We've looked at outside of the country. I'm happy to take that question back and follow up with a written response.
Okay, that would be great. And if there is any follow-up, they can just send that to CCHP and we'll make sure to post that with all the other information. We have other questions for our Texas speakers, but we are going to move on to our next panelist here, which is from Fran Hunter, who is from Kansas. And Fran is a RN with a BSN and MS in counseling. Currently, she's employed with the Medicaid division of the Kansas Department of Health and Environment. Within this position, she serves as an interagency liaison for other state agencies who access Medicaid funding. And also, among other assignments, she also is assigned to a program on telemedicine coverage. So I'll now turn it over to Fran.
Hi, you can move the slide. Thank you. It was interesting timing. I got the telemedicine assignment just prior to the pandemic hitting. So I had a very large learning curve, although working in Medicaid, our clinical staff communicate very, very closely with each other. Basically, prior to the pandemic, we basically pretty much aligned our telemedicine policies with the Medicare guidance. We kind of thought that gave us some guardrails and some structure to help us make decisions as we moved forward. But we did have some allowances that Medicare would not have allowed. We didn't restrict just to rural areas. And of course, with the pandemic hit, a lot of things were opened up on a temporary basis. Some of them were specific guidance and allowances from CMS, which included the fact that we could allow services to be provided in the home, and also audio only was also opened up for us, and we took advantage of that. So we are kind of like some other states that we've been hearing about with what we had previously allowed, which I'll get into later since this is about behavioral health. Our behavioral health providers were basically the leaders in use of telemedicine prior to the pandemic, and they continue in that regard while we're in the middle of the pandemic. They are probably our heaviest users of telemedicine options. Next slide, please. So we had some new providers coming in that were going to be providing some of our behavioral health services that had not previously done telemedicine for us. And there were some, of course, that were going to be expanding what they could do. So we just felt like some reminders would probably be a good idea. And many of you who've done telemedicine are very familiar with this, so I'll go over them really, really quickly. We do require that they be real-time, interactive, synchronous, audiovisual, unless we made specific allowances for telephonic, and we did allow some codes to be delivered in that way. We reminded people of the definition for the distance site. We're different than Texas in that our distance site, we require the O2. CMS replaced the GT modifier, which again, we don't reject claims in our system with the GT modifier, but it's informational for us. But we want, if they're doing telemedicine, that the place of service be an O2. The originating site, of course, is where the patient is. If they're going to bill us the Q3014, which is the telemedicine originating site facility fee that we pay, the provider has to be physically present in that location. We do and always have reimbursed at the same rate as if they were in the same room with each other face to face. And we do caution people that you need to make sure if you're serving a Medicaid beneficiary that the codes are covered. And if you're doing it via telemedicine, that we have allowed that particular service code to be allowed via telemedicine. We are like Texas in we do not cover communication that's email or fax. And we do require that documentation should be the same as if you were in the same room with the person. Next slide, please. We also let people know that even though the expansion of codes, we were going to broaden it for telemedicine, it didn't change or modify the current coverage. So if you were an allowed provider before, you were going to be an allowed provider with telemedicine, but we didn't expand the provider type or specialties that could provide this. We didn't lift any of the NCCI editing. We were not waiving that. We gave a reminder about the appropriate use of the Q3014. We did open up home, but we knew frequently that there would not be a provider in that setting. It would just be the individual communicating with their provider set. So we just reminded people that it wouldn't be appropriate to bill a Q code. We did indicate to people that they needed at least a verbal consent initially to provide telemedicine services. We knew folks might not be in the office right away to sign a written approval for the medical record. Some of our providers did that through sending a mail that they wanted returned. Others, when it started to open up a little bit, actually had folks sign it. But we will be expecting to see a written consent in the medical record moving forward. And let's see. Yes, and the same thing about the Q3014, kind of a repeat. Our governor did allow out-of-state physicians to provide telemedicine in Kansas without a Kansas license. That was new for us, but they had to have an unrestricted license in the state in which they practiced. And she did not, our Governor Kelly did not open up this allowance to any other licensed provider. It was only specific to the physician. Next slide, please. We, like many people, were optimistic that this was going to be a short-lived pandemic. So originally when we wrote our policies, we matched them up with our gubernatorial executive order, which was set to expire on May 1st or sooner. Again, optimism. But when it became very evident that this was going to go on for an extended period of time, we had a lot of providers getting very, very anxious and antsy about when are you going to change it? Is this going to continue? So basically, we changed all of our policies that basically stated that if it was extended, it was in effect until we specifically rescinded it. And we will give providers a lead-in time because we know some folks may need to change a little bit about their service delivery. So we've pledged to give a minimum of 60 days before we would roll any of those back. We knew that in some cases, some of the things they were going to emphasize or work on in the treatment plans, maybe we're going to take a little bit of a shift, or we knew that because of the pandemic, especially since these are behavioral health services, there might be new issues that crop up, stress related, depression, that sort of thing. We really wanted providers to take a careful look at their treatment plans and update them if they needed to. We in Kansas have had coverage for telemedicine since at least 2004. I again took this program on relatively recently, but that was the oldest policy that I could find related to telemedicine coverage. We had help in that because Kansas has a lot of rural and even frontier states. We actually, through our community mental health center, had gotten some funding to set up some telemedicine stations and were provided funding for technology. So that helped us when we decided to roll out for the allowance of telemedicine. We have one center, for example, that covers 20 counties in the northwest corner of our state. And within those counties that they cover, more than half of them are technically frontier. So they're really spread out. So the technology that was funded not through Medicaid, but through other sources, helped us kind of expand our telemedicine service. So let me tell you a little bit about the Kansas demographics, which would be on the next slide, please. Which kind of gives us support for why we really kind of want and need telemedicine. We have about 14% of our 2.9 million folks covered by Medicaid or CHIP. Our caseload is around 408,000 monthly. We did not in Kansas as yet expand. We're not a Medicaid expansion state. We anticipate if we would ever become that, our numbers would grow, of course. We have 105 counties. 66 of those counties meet the definition of being medically underserved. We have a $3.8 billion budget for our program, Kansas Medical Assistance Program. I gave you kind of some of the physical attributes of Kansas, 82,278 square miles. It's the 15th largest state by area, but 34th and the most populous of the 50 states, 213 miles of length and a width of 410. About 26% of Kansans live in a rural area, but we also have a frontier area. And we in Kansas are heavily a managed care state with about 98% of the individuals I talked about with Medicaid coverage being assigned to a managed care entity. If you'll move to the next slide, please. That will just give you the population density as of 2019. And you can see we definitely have some urban and semi-urban areas. We also have what would be considered densely settled rural areas, but you can see we have rural and frontier. And the northwest corner of the state that I told you was covered by that one CMHC, you can see a lot of them fit in that category of rural and frontier. And then the next slide, please, will show you kind of where our CMHCs are located and where our mental health professional shortage areas are. So you can see that quite a bit of our state is considered a professional shortage area. There are a very few over in the eastern part of our state, which is more heavily populated, that has, even them, they will tell you they don't have enough of the mental health professionals to go around, but they are certainly better situated than some of the other counties. So if you'll move to the next slide, please. As I told you before, we've covered telemedicine since at least 2004. And again, that was the oldest policy I can find. So I think that that's accurate. We've covered it for behavioral health since 2004. Consultation, office visits, of course, the evaluation and management codes, individual psychotherapy, pharmacological management. And then over time, we've added a few codes to that periodically. But when the pandemic hit, it meant that we opened up almost all of our behavioral health codes. We are the mental health authority rests in KDADS, which is our sister agency, the Kansas Department for Aging and Disabilities. I work for the division that's the state Medicaid authority. And because that's really their oversight, there was very, very close work with them. And they did a lot of the legwork with us kind of being peripheral in terms of working with the Association of Community Mental Health Centers. And we have two statewide SUD associations, did consultation with them, talked with them, and came to an agreement between the two agencies, KDADS and ourselves, in terms of what we were going to expand, whether we're going to allow telephonic, whether we're going to allow it in home, that sort of thing. We did try to really carefully evaluate what was appropriate, what would help beneficiaries stay connected to their providers. We know that and you hate to acknowledge this because you hate for it to be true, but I know some of our providers were really worried if there wasn't work for their folks to have, they might lose them to other providers. They might even move out of state. So there was a need to, as much as possible, to preserve the network of providers in addition to providing assistance for our folks, because we anticipated that the behavioral health services were going to be in high demand, because we knew even those of us who didn't have those issues before were probably going to experience a degree of stress and discomfort, and the world has changed all around us, and what's our role in it, and that sort of thing. In addition to that, even though I don't have it on the slide particularly, in Kansas, we do have a serious emotional disturbance waiver for our kids. So when we did our expansion for the behavioral health services, we did do an expansion within that particular code set. We even opened it up for attendant care to be provided, telemedicine. We know for some of our kids that have some of these very challenging emotional issues, that a lot of times this was kind of be an anchor for them. And we wanted them to stay connected to those folks. So that was very deliberate on our part. Okay, next slide. We also cover crisis intervention. And we knew that for individuals that were already being served through the mental health arena, might already have an association with their providers, might already have a treatment plan that talked about, anything that might alleviate or mitigate a crisis, that there would be some new folks reaching out. But we also we wanted to put some kind of safety around that. And so we kind of built in the fact that if a particular center was going to provide crisis intervention via telemedicine, that they had to present a plan for Arcaded's partner to evaluate. They would review the plan. If they approved it, then they were to give them a particular start date. The CMHC would be expected to keep that in their medical record for potential review. And we also let our 3 MCOs know, as well as we as the Medicaid agency were made aware that this approval had been given. Next slide. Many of you will have these links, but we thought it might be helpful to put them in here. These are a lot of the links that we've used over and over again. We've got the HHS links. We've got the CMS link. And in that list of telemedicine or telehealth services for calendar year 2021, if you've looked at it, some of the codes that are covered via telemedicine are in there for the duration of the pandemic only. They're in there on a temporary basis. Others are of a more permanent nature. So that's a helpful list to kind of look at and keep in mind. When the pandemic hit, we were really scrambling as fast as we could to open up the services. We did not go back to all of our provider manuals, including the behavioral health manuals, the mental health, and the SUD manuals, and specifically put in those manuals, those codes that would be allowed for telemedicine, in the home, telephonic. But we knew that would be an important thing for providers to know. So in addition to what we already had opened up for telemedicine, which can be found in that first link, we also established a special place on our fiscal agents website where providers could go out for specific policies related to the pandemic and find COVID specific policies, which would tell them, was it covered additionally for telemedicine? Was it covered if the person was at home? Was it covered by telephone? Those sorts of things. And those were all in a special section on our fiscal agents website. And a lot of our providers know to go to that website to get to that particular area. Next slide. So we've got in here a link if you want to look at our provider manuals for what we allowed prior to the public health emergency, which are down below, and it's the mental health and the SUD manual that I referenced just a few minutes ago. And then the last slide is going to give you information if you want to reach out and contact me if you have special recommendations to make for us, or special observations, or just have various questions you want to ask, that's fine. We are constantly bombarded, and I say bombarded, and I don't mean that lightly, from providers wanting to know, how long are you going to keep these in effect? When will they be rolled back? How will we know that they are rolled back? And basically at this point in time, we're holding steady till a declaration has been made for a lifting of the public health emergency. We've given thoughtful consideration about the positives and the negatives that have been communicated to us. We've been keeping our ears open since shortly after the pandemic. What's working for you? What's not working? What kind of feedback do you get? We've had particular stakeholders meetings where we ask that question almost every time. We are asking our associations for that kind of feedback. We've had some forums where we've had actual members that have provided feedback. So we're trying to take all of those things into consideration in addition to what we consider clinically appropriate as we move forward, as we make those decisions. We have pledged to let our providers know with at least a 60-day minimum that if we're going to do any shifts on them. So it will be interesting to see. We anticipate from everything we're hearing, probably the declarations is not going to be lifted until the end of the year, but we're keeping our eyes closely on CMS because some of what CMS decides will also drive what we are and able to do in Kansas and what our policies may have to shift on and how much flexibility they will give us to maintain what we have established during this special time. So that concludes my particular presentation.
Thank you, Fran. And just a few things before we get to the questions for Fran, which, by the way, if you have one, please put in the Q&A function. Yes, copies of the PowerPoints will be made available after the webinar. You will find that on CCHP's website at cchpca.org. So you will have access to copies of the PowerPoints a few days after the webinar. All right, Fran, let's just get to some of the questions that we have for you. First one's from Amy, and I apologize if I'm mangling your last name, Shion, who asked, are any efforts underway to assess or improve telehealth readiness among patients? For example, whether they have broadband, connected devices, and digital skills.
We have done a little of that. We have had, with some of the money that's come down from the federal governments and also with the assistance of our MCOs, we have been able in some cases to provide iPads, phones for some of our individuals. We have not, some of the MCOs have done a little bit of training. Some of our, trying to think of the right word for it, but some of our partners have taken that upon themselves to assist individuals. Not everybody, of course, is comfortable with technology. We know, just like a lot of other states, internet is very spotty and non-existent. We call it the internet desert. And that's why we felt very, very strongly that some of these codes needed to be opened up for telephonic contact. And I hope that answered the question, but we probably from the Medicaid agency specifically have not done training to assist our members, but have encouraged the advocacy groups that are that have gotten some funding for technology. Our MCOs have done a lot of work in that regard to reach out and assist individuals in that regard.
Thank you, Fran. And speaking of MCOs, Tanya Harris does have a question regarding those managed care organizations. She's wondering if they offer peer services for substance use disorder, or if so, who is providing that if they don't do that?
Peer support is allowed from both our SUD providers as well as our behavioral health providers, the CMHC area particularly. So both of those areas are able to do that. And I want to look at my grid so that I tell you for sure correctly, because I don't want to say something that's not right. We have opened up peer support for in the home. We have opened up peer support televideo, and we've opened up peer support telephonic. We know that for some folks, actually reaching out to a peer who's also experiencing the same issues that they're experiencing with the pandemic, the isolation, the depression, you know, all of the things that go along with it. We have found from feedback that for some of them, that has been a very valuable lifeline, and that's why we opened that particular service up very broadly. And again, SUD providers can provide it, and our behavioral health, if they're a CMHC, can provide it.
Great. We'll take one more question for Fran, and then we'll move on to our next speaker. The last question is, if a client is on an internship in Colorado and their permanent address continues to be at their parents' house in Kansas, can telehealth mental health care continue during their out-of-state internship, or do they need to be transferred to a provider in Colorado?
We did not consider ourselves the expert on that. We had a couple of questions come in about that early on, and we connected with our behavioral sciences regulatory board. They were adamant that a provider that was licensed in Kansas could not provide services outside the state line. That had to be provided within the state border.
All right. Fran will be back along with Texas for our full speaker panel, but now we're going to move on to Massachusetts. And we have with us today from Mass Health, Dr. Clara Felice, who is the Deputy Chief Medical Officer for Mass Health, where she provides clinical and strategic leadership to support delivery of high quality, high value care. She also advises on key strategic initiatives, including related to social determinants of health, care of children and adolescents, and health equity. Dr. Felice previously served as lead clinical advisor for restructuring of Mass Health's delivery system to promote integrated coordinated care through a transition to accountable care organizations. She earned her MD and MPH degrees at Northwestern and completed pediatric residency training at Lurie Children's Hospital in Chicago. She was a Robert Wood Johnson Foundation clinical scholar at the Yale School of Medicine, where she completed a Master's of Health Science degree focused on health services research. She is board certified in pediatrics and continues to practice in the Boston area clinic. So Dr. Felice.
Thank you so much, May. Great to be here today. Really interesting to hear the experience from other states. Go ahead and move to the next slide, please. I'm going to talk today about our experience in Massachusetts with telehealth more broadly and including behavioral health services. And you'll see as we go through, I'll kind of touch on both pieces. So just to begin with, in early 2019, Massachusetts was already interested in exploring expansion of telehealth services, specifically for behavioral health services. And just to offer a few details about that policy, of course, pre-COVID, so at this point, somewhat historical, which we'll get into in a moment. The services included at that time counseling for opioid treatment services, a host of ambulatory services, including outpatient counseling and clinical case management, and outpatient services in particular for pregnant and postpartum clients. So really focus on a segment of behavioral health services that were particularly thought to be amenable to telehealth at that time. We did pay at parity with in-person services for those services, and we did require use of secure interactive audio and visual telecommunication systems that permitted two-way real-time communication between a patient and a provider. We had just begun to evaluate early impacts of that policy, of course, when COVID came about, prompting Mass Health in March 2020 to introduce a broader telehealth policy. And I'll just share a few details about that here. So first of all, our telehealth policy, which remains in place, by the way, allows all clinically appropriate, medically necessary Mass Health covered services to be delivered via telephone and live video telehealth modalities. We pay at parity with in-person services, regardless of the mode of transmission or the service. We do allow preventive visits to occur via telehealth with some stipulations in place around expectations for completion of hands-on components of preventive visits at a future date. We did introduce a specific remote patient monitoring bundle for COVID care specifically. So really designed in particular at a time early in the pandemic when we were experiencing a surge in inpatient hospitalizations. This was really designed to facilitate very close monitoring and care of patients in the home who didn't require hospital level of care, but required close observation from a primary care or other provider. We didn't impose in this policy specific requirements for technologies used, but did require members to consent to any privacy risks. And of course, like many other states, this concession was made under regulatory flexibilities from the federal government that allowed use of non-HIPAA compliant devices in particular during the pandemic in order to facilitate access because of the rapid and abrupt transition that was needed to facilitate ongoing care for members. And then finally, just mention here, we've taken an expansive view on what constitutes telehealth, and in particular did expand our support to the CMS Acute Hospital Care at Home program, which allows for hospital level of care delivery in the home for specific home amenable conditions. And we have two major provider systems here in Massachusetts that have been providing these services for some time, and under flexibilities under the federal PHE, CMS expanded this and allowed us to facilitate this to be available to our Medicaid members as well. Next slide, please. Just briefly to describe a little bit about our experience with telehealth to date, particularly since the COVID pandemic. This will be probably familiar to a number of folks across the country, but just to kind of provide some basic information. First of all, when we first introduced our behavioral health telehealth policy in this early 2019, we did see, of course, an increase in utilization at that time, but modest compared to what we saw beginning in March 2020, where we saw peak utilization of our telehealth services in April and May of 2020, with a gradual decrease over 2020, and then stability, which has persisted even into this spring and into the summer, we expect. Telehealth, however, only made up for a proportion of the decreased in-person utilization that we saw. And folks saw this, I think, pattern in a number of places across the country as well as nationally. So while it definitely played a key role and was used widely for a number of things, it did not replace all the inpatient care that would have been anticipated during, in particular, some of the peak era of COVID periods in Massachusetts. We are seeing data on member experience as well emerging in a number of different settings and related to the experience of specific populations. We have seen that satisfaction with telehealth is on par or above satisfaction with in-person care in many circumstances. And this has been a persistent finding across age categories, demographic categories, service-based settings, et cetera, different geography in our state. We've seen a strong preference for telephone-only services in some contexts, which has been really interesting. And as you can see, will be one of the things I'll talk about in a moment with regard to considerations for future state. We have seen some variability, of course, in experience by demographic characteristics, including social risk factors such as race, ethnicity, language, disability, geography, again, service setting, et cetera. And we have seen, interesting experience and report of experience emerging with regard specifically to behavioral health services as compared to physical health services. We saw tremendous uptake, particularly in behavioral health services early on in the pandemic, like everything else, and many have persisted. But we are also beginning to hear about experiences with children with telehealth and how they may be different than those experienced by adults, et cetera. Next slide, please. So moving forward, a number of considerations that I'll go through. So first of all, in our current policy, which remains in place, Massachusetts actually just announced recently that we'll be ending our state of emergency on June 15th. So we're actually, obviously contemplating what comes next. And these are some of the things we're thinking about. So in current state, we've been considering adding remote patient monitoring services for chronic disease, which allows for more real-time interactive approach to managing chronic disease like hypertension and congestive heart failure and other diseases that allow for submission, often electronically, of blood pressure readings, of weights, et cetera, to clinicians who can then interpret them and provide guidance electronically, not requiring a visit. So we are considering adding a set of services related to that. We are also considering adding coverage for provider-to-provider e-consultations. And we just recently submitted an 1115 waiver request to continue hospital at-home programming post-public health emergency, as well as a number of mobile health interventions like mobile integrated health that allows for evaluation of members in their homes, lab draws, and things like that. Next slide, please. There, of course, like others, there are legislative and other impacts on how we're designing our telehealth policy. And in particular, legislation was signed into law in Massachusetts in early 2021 that has some relevant provisions for our telehealth policy moving forward. We will be required to maintain parity between rates for services delivered via telehealth and services delivered in person according to the following kind of constraints. First of all, the first 90 days following termination of the governor's emergency declaration, we must provide parity in rates for all services rendered via telehealth modalities. And then through December 31st, 2022, specifically for chronic disease management and primary care services rendered via all telehealth modalities. And so this is inclusive of both audio and video. And then permanently for all behavioral health services rendered via audio, video, or audio only telehealth. So there's been strong support from leadership at Mass Health, at our Executive Office of Health and Human Services and our legislature for behavioral health services specifically to be allowed flexibilities in terms of telehealth services. And so you obviously see that reflected here. Next slide, please. Other considerations, of course, and many of these have been highlighted to some degree in earlier presentation. We recognize very much so that our patient and provider preferences have shifted, that this experience of delivering telehealth during the pandemic has really changed the way people think about it as a modality in the clinical spheres. So many very much like telehealth and have become accustomed to its use, of course, not all. And I think, we are working, as many others are, to understand kind of how that distributes. Second, we know that many of our providers have invested heavily in telehealth infrastructure and will likely seek opportunities to continue to utilize that in the future. There are, of course, a whole host of equity considerations around delivery of services via telehealth. For example, just a few listed here, but not meant to be inclusive of all. Disparities in access to broadband, to minutes, to devices, the role of telephone-only telehealth when you think about comparability of care and how that distributes across populations. And of course, the potential advantages that telehealth may provide, in particular to our members who are otherwise taking time away from work and or families to travel to in-person visits. We also know, of course, that the evidence base around the quality of care delivered via telehealth for physical health, behavioral health, long-term services supports, et cetera, is very much still emerging. And this is largely a function of the fact that before this grand experiment that we all entered into at the beginning of COVID, telehealth was not very widely used in many places in our country. And so we don't have a mature evidence base around when it works best, when it is comparable to in-person care, when it may be better than in-person care. So we don't have that evidence yet, although certainly that's being built as we speak. And in particular, we're very sensitive to the fact that it's not one size fits all, that telehealth may be great for some things and or some of our members, but not for others. And so trying to be very sensitive to that. And then finally, I'll just highlight that we are having a number of statewide discussions, not only within Mass Health, but also with the other major payers in our state about the future state of primary care delivery, and of course, including our providers, which we are contemplating and discussing at this point the potential for moving towards global budgeting for primary care, which would, of course, have implications for telehealth. And this is amongst a number of other alternative payment model and value-based purchasing discussions that are going on across the state. So thinking carefully about how this intersects with overall the value-based purchasing environment in our state. And then moving on to the next slide, please. Happy to answer questions and appreciate everyone's time and attention today.
Thank you, Dr. Felice. I actually have a quick question for you because I could not remember this, but are your telehealth waivers tied to a state public health emergency or the federal one?
So ours are, like everyone else, policy was developed kind of over time, but generally speaking, we are largely tied to the state public health emergency. There are some circumstances in which they are tied to the federal public health emergency as well. And so we're working to sort of streamline all the expectations such that providers are not held to a variable set of standards.
Okay, so that's very important to know for those who are using telehealth in Massachusetts, since you mentioned that the state will be declaring the public health emergency over within a couple of weeks, that it's going to vary probably from what's going on the federal level too. So just be aware of that, folks. All right, we have a couple of questions for you. One of them was, let's see, could you talk more about the differences between children's and adult experiences telehealth, or will there be findings shared in the future?
We have not shared publicly any of the findings yet. We have them coming in from a variety of different sources, but we are seeking to share that publicly in the future, and so would be happy to do so. I think generally speaking, as you might imagine, we know that in particular, for adolescents, the experience is very different from that of children and families who are seeking services related to autism, for example. So we are trying to think about it carefully and look across the pediatric population to understand what experiences look like. And we'd be happy to share that at some point in the future.
We have a question from Jordana Bernard. In Massachusetts, there is a requirement for telebehavioral health prescribers of Schedule II medications to have an in-person visit with the patient every 3 months. Is there any support to remove this restriction?
It's a good question, and happy to take that back. We have not heard a great deal from our provider community, our member community about that to date, but appreciate the flag.
Does the Commonwealth have reciprocity with any other states for providing services by providers licensed in Massachusetts? Specifically, can we treat clients moving to New Hampshire or Connecticut?
There has been a fair amount of discussion about that to date in Massachusetts. There were some flexibilities that were introduced by our state board of medicine to allow for, in certain circumstances, providers to treat patients across state lines. To date, it's been tied largely to the state of emergency, but that is an ongoing discussion, and I think it will be not just in Massachusetts but across the country, given how telehealth has changed the landscape.
Okay, so I'm going to actually ask all of our panelists to come back now for our remaining time here to have an all panelist discussion. And there are a couple of questions here that look like that they could be applied across all of you. I'll start off with my own question because actually, Dr. Felice, you mentioned that this was made permanent as a policy, and that's audio only. So I've heard a lot from other jurisdictions of using audio only and how beneficial that's been for providing it for mental and behavioral health services. So we've heard from Massachusetts that it's actually been made a permanent policy now, allowing audio only to. Oh no, you're shaking your head.
So the legislation does require it. It's not been operationalized yet because the state of emergency was just recommended to be ended, but the legislation was pretty specific about expectations related to audio only. That's correct.
Mm-hmm. So I was wondering for Texas and for Kansas, what are your policies now around audio only, and will that possibly stick around? Something similar to like what Massachusetts is doing, or maybe like a narrow band of services, or maybe it will just disappear?
I know in Kansas, we are probably going to carefully consider. There are some codes that are not necessarily behavioral health codes, but that we do allow telephonically now, that we probably will not allow after the emergency is over. But there'll be wide discussion before we change any of that. But we haven't really entered into heavy duty discussion about what we're going to allow telephonic and what we aren't.
In Texas, we do have some pending priority legislation. Our legislature, as I mentioned, is currently in session and actually will be concluding the 87th regular session on May 31st. So there is a piece of legislation that would require HHSC to the extent that the services are clinically clinically effective and cost effective as well. So it adds a cost effectiveness component to the coverage for audio only behavioral health services. It also it requires that we do look specifically at those services and then and do include some for coverage. And then it also has a second component that would require us to do the same type of analysis for any other services that we deem appropriate for audio only delivery.
Great. We have a question regarding data on member experiences. Is there any type of report or data that any of you can share regarding what member experience with telehealth has been?
In Kansas, I know we don't have anything formalized. We're gathering information, but we don't have anything, like in a formal report yet.
For Texas, we're really in the same position. We've done a number of provider surveys, some of which the data will start to be released this summer, but we're still, I think, in the same position as Kansas in terms of gathering member or client-specific experiences with telemedicine, telehealth. We have some kind of informal information that we've gotten, and some other divisions within HHSC have gathered some information informally, but nothing that's been published to date.
We have a follow-up to the audio-only question from Lindsay Baywell. How would states implement audio only? Would it be written in policy that certain procedures could be done via audio only, but nothing systematically checking this? Or will it be operationalized in that only specific telephone only codes will be covered, or perhaps both? Indiana wondering how we can audit specifically for audio only telehealth in the future.
We in Massachusetts have, to date, we use a modifier to signify telehealth delivery. It's not specific currently to whether it's audio or video, but we are working towards a system where we can allow providers to indicate whether they're using audio only or audio video, such that we can track it over time.
Okay, so let's see. We have a question here. Are there any studies on effectiveness of evidence-based practices when delivered via telehealth that you may have consulted or used, or would you like to see more information regarding that?
The more information we can get to support what we're doing, we're always open up for that. And I keep my eyes and ears open for anything, but I'm not seeing anything real specific to evidence-based practices as it relates to telemedicine specifically. I'm not saying it's not out there, I just haven't stumbled across it.
Yeah, we've kind of scoured the literature base out there and have found in general some of the most advanced evidence is related to things like teledermatology and specific cardiac care functions and other things. And that just reflects the fact that I think those were some of the earliest and emerging programs and uses for telehealth before COVID came around. Of course, we widely expanded our expectation of what telehealth can be used for. And of course, utilization followed that during, but we are, scrambling to I think nationally to take all the extensive information that we have about telehealth utilization during the pandemic and try to translate it into an understanding of what the impacts are. We of course would be very interested in any evidence that folks can offer in terms of what's high quality and equitable telehealth care.
Are there certain type of research that weigh more favorably in your eyes than others? Like, for example, published peer-reviewed journal articles hold more weight than maybe just sort of a white paper a health system maybe did on what their patient population said. I mean, are there certain levels where you're saying we kind of lean more towards wanting to see this as opposed to this type of information or research?
I think there's room for both, for a wide variety. I mean, of course, published peer-reviewed journal articles are, often considered to be the gold standard. But that's another thing that changed during COVID, right? Our journals started publishing things before they were fully peer-reviewed and otherwise sharing information more expansively. And so, there's such an information vacuum right now about telehealth. I think anything that contributes to our overall knowledge base would be valuable.
So there's actually been, especially during COVID, a lot of discussion of crossing state lines and providing services, and especially because of telehealth and the reach that it can have. And we heard from Kansas that the governor, at least temporarily, allowed non-licensed providers to provide those services within their state. Do you guys foresee that continuing in some capacity, a little bit of relaxation of those licensing laws, or maybe reciprocity, as we had an earlier question regarding that?
Well, and I want to reiterate that only allowed physicians. So it was very, very restrictive, and there was actually quite a bit of pushback even on that. People understood it, but whether that will stand beyond that. I'm a little bit suspicious that it will not,
Mhm.
but it was only physicians in Kansas.
All right. Again, if you have questions for our panelists, please type it into the Q&A function here. And for those who are seeing that maybe their questions aren't asked, I am combining some of these questions because we do have certain themes going through here. Let's see, what else do we have here? There are some questions here regarding social determinants of health for patients and like what are some of the telehealth flexibilities can be used to like address those. Now we saw some of that because of the wide flexibilities that were allowed during COVID, but do we see that possibly also continuing beyond the pandemic in like your various Medicaid programs?
At least in Texas, that's something that we've looked at pretty extensively. Obviously, we live in a state that I think like Kansas has everything from very urban areas to extremely rural areas. And we're also the second largest in terms of land mass. So we really do look to try to use telemedicine and telehealth services to promote, both access and equity. We've been focused recently through different reports and studies that HHSC is conducting on the intersection of use of remotely delivered services, broadband access, really just, internet accessibility in general, with a specific focus on our rural communities. So rural health clinics, as well as rural hospitals as well. So we've been doing a lot of work in that space and engaging with partners in particular on those issues.
For Erin and Fran and Tamara, I know both Texas and Kansas have fairly robust school-based telehealth programs. I'm not as certain about Massachusetts, but what we saw also during COVID, obviously, were increased mental health needs, especially for children as well. So are we going to possibly see those programs continuing beyond the pandemic? I'm pretty sure probably in Texas because you guys had a pretty robust policy in place before the pandemic to begin with, but are they going to possibly be expanded in some ways?
I think the question for us is because of how many we opened up, it's not necessarily expanded, it's whether we will pull back or roll back any that we have allowed. Because if you look at our allowed, what would be considered behavioral health services, there are very, very few that we don't allow through at least the televideo aspect. So again, I think if there were changes, it would be more of a rollback nature rather than an expansion because we don't have that many codes left to expand to.
Okay, we have a question from Lindsay Baywall again. Governor Holcomb of Indiana allowed physical therapy to be performed via telehealth under executive order, so long as there was a video component. What are the feelings of the other states in allowing PT and OT therapy?
Well, this is Tamara, and that's a great question. Actually, my manager is a PT/OT person. I would have to refer back to her, kind of check on that with her, what she thinks and what would her recommendation be, unless Erin seems to know.
Well, we do. We actually do have a speech language pathology, a telehealth speech language pathology, and telehealth occupational therapy benefit. It's for both school-based settings. So it's for clients who are receiving expanded EPSTD services, as well as clients who are in our school health and related services program, as well as our early childhood intervention. So it's both IDEA Part B and Part C as well. So we do have, at least for pediatric clients, it was existing benefit for those services. I think we'll definitely be looking at physical therapy services and looking to make similar changes specific for those as well to kind of match what we've done for OT and SLPs. And again, we have legislation that would specifically direct us to do that work. That's priority legislation.
I think for some of these questions, our speakers and panelists may not be able to answer them because there is pending legislation as well that might be directing them to do certain things in the future, or they're not able to speak about it because the legislation hasn't passed yet. So that's also a consideration and aspect of this too.
And
We've
May-
got a question. Oh, yeah, go ahead.
I'm sorry, May. I do know that the Oregon Health and Science University, their Center for Evidence-Based Policy, they are really focusing. They've announced their topic nominations for the year, and there are a couple of them that are focused on telehealth and the fidelity of delivering services through telehealth. So I think through that, we will get more literature on how effective telehealth has been and what the outcomes have been.
Yeah, I think we're probably going to get a bit of a flood of literature within the next couple of months or a year on what has happened during the COVID with telehealth. All right, we've got a question from Ankit Gupta. Do you have any thoughts around increasing access to medication-assisted treatment via telemedicine? CMS introduced 3 new bundle payment codes, G2086, G2087, and G2088 in an effort to do that. They haven't been widely adopted yet in Medicaid plans, unfortunately.
Some of it has to do with the regulations and oversight of the medication portion of the MAT. We've allowed the counseling portion of it to be done via telemedicine, but some of the med administration, there are restrictions and rules and regulations, some at the federal level and some at the state level, that require there to be a physical handoff. So some of that is going to be driven by regulations outside of what the Medicaid agency will have the ability to change.
All right, we are going to take one final question from the audience here. It's from Diana Curing. Again, I apologize if I'm mispronouncing your name. Have you done anything specific to language access services to support Telemental telehealth, including use of interpretive services?
So on the Texas side, we have a very large Spanish-speaking population, especially in our frontier areas, our border areas. So we have provided services with interpreters, or we use language lines to assist with interpreting services for a very long time. We can convert like treatment plans to Spanish. We do that often. So we have a lot of different types of ways that we are able to, especially for the Spanish-speaking population, are able to communicate with them in their native language. Yes.
All right, then. Well, I want to thank our panelists for taking the time to do this and present on this great webinar. If we can have the PowerPoint back up here. Thank you again to Fran Hunter, Tamara Boyd Ostrout, Erin McManus, and Dr. Clara Felice. We really appreciate you guys taking time to present today and to provide such great information for our attendees. Next slide. A recording of this webinar will be made available a few days later. You will also be able to access copies of the PowerPoint as well. You can just go to CCHP's website for that, or CCHP's YouTube page. Next slide. We are planning a fall Medicaid webinar series. So that should take place sometime in September or October, or during both months. It might cross over there. So please stay tuned for information regarding that. You will also receive an evaluation after this webinar concludes. So please fill that out. That would really help us in our future planning on certain topics, and also particular states that you might be interested in hearing from as well. So please fill that out when you receive that link for the evaluation. Once again, I want to thank all of our speakers for providing us and out of their busy schedule, providing us with their time and effort in presenting on this webinar. I want to thank the CCHP staff for your help in pulling this together, and I want to thank all the attendees for attending today. Hope everyone has a great day and stay safe.
Thank you, May. Sorry for the technical issues on my end.
Not a problem.
Bye.